So this is the part 2 for the intestinal obstruction. In the part 1, we have discussed about the different types of the intestinal obstruction, their classifications, and we'll talk about the volvulus, the intussusceptions, their presentations, particularly about the different kinds of the symptoms, or like the abdominal pain, distension, and vomiting and constipation, which can be relative or absolute. But particularly in this segment, we will be talking about the different types of the management strategies which we have available for the intestinal obstruction. Right? So if a patient is coming to you with the symptoms of abdominal pain, constipation, and vomiting, and as well as you can see the abdominal distension as well, you can have a bit of the idea that this is a case of the intestinal obstruction, right? And then you order for some kind of the investigations like the x-ray for abdomen, like the abdominal x-ray for erect and supine positions, and for the emergency, and also if the CT scan modality is also available for you, then you can also order for the CT investigation for that particular case of the intestinal obstruction. But now comes what kind of the management strategies we have for the intestinal obstruction. Some are supportive management strategies, and some are the definitive management, right? So you have to identify which kind of the segment of the bowel is involved, whether it's a small bowel obstruction or a large bowel obstruction, because in case of small bowel or a large bowel obstruction, the segment resection, proximal or distal, and the length of the segment, these things all are very much important for the definitive management of the intestinal obstruction. So what steps we are going to take for the supportive management? First is a nasogastric decompression, and other is the antibiotic therapy. How we are going to do that? First of all, you have to NPO the patient, nil per oral. You have to discontinue any kind of the fluid or any kind of the food to the patient. You have to discontinue all of them. You have to put the patient on the IV fluids, and you have to pass the nasogastric tube down to the stomach, so that if there are any contents which are present, because most of the time what happens that actually this is the proximal segment of the gut loop, which is being proximal to the point of the obstruction. So that particular segment which is present at the proximal side, that is full or dilated because of the fluids and because of the contents, gastric secretions or salivary secretions or the pancreatic secretion. So most of the time what you do is that, because the stomach is in continuity with the duodenum, and then we have the jejunum and the ileum, and then starting from that you have the part of the cecum and the ascending colon, then transverse colon, then descending colon, which are the part of the large intestine, right? So in case of the small bowel obstruction, I told you in my previous lecture that the vomiting will be more pronounced. So for that you have to pass the nasogastric tube, which is basically the nasogastric decompression. And what happens that whenever NG tube is passed into the stomach, whatever the contents, whatever the secretions which are present in the stomach, they're being aspirated, and because of that there will be the effect of the decompression, and some kind of the symptoms of the patient will be relieved. The second plus, you have to put the patient on the fluids, like 3 liters of fluid in the 24 hours, because if you are ordering the patient to be NPO for the 24 hours, so 3 liters of the fluid, which is the minimum requirement of the body, that should be delivered to the patient who is NPO for the 24 hours, right? You have to, but the choice of the fluid, this is very much important, because in case of the small bowel obstruction, in which the vomiting is more pronounced, vomiting is very vigorous, there's a loss of sodium, there's a loss of water as well, so you have to replace that, right? And for that the best solution is a Hartmann solution or a normal saline. So you have to give 2,000 liter of normal saline in the 24 hours and 1 liter of 5% dextrose, because you have to, the glucose requirement of the body, you have to fulfill that. So you have to consult the hematologist whenever you're managing such kind of the patient for the fluid replacement. So you have to manage accordingly, and you have to consult, involve the medical specialist or the hematologist which is available in your premises for the fluid therapy, because this is very much important. Because most of the time, in case of the small bowel obstruction, the patient goes into the electrolyte imbalance, and because of that electrolyte imbalance and the dehydration, the patient goes into shock. So you have to prevent particularly the likely or the recurrence of the shock. So for that, you have to hydrate the patient. You have to give a good hydration therapy, so that the insensible water loss and all the fluid in the water and electrolyte loss in case of the vomiting, that should be replaced. The other thing you have to use is the antibiotic therapy. But antibiotic therapy is not, a definitive kind of thing you should do, because you are giving the antibiotic therapy prophylactically. But if you're preparing a gut for the laparotomy, like it's a case of strangulation, or it's a case of strangulated external hernia, or it's a case of the volvulus, and you have to open the patient, you have to perform the laparotomy, then you must have to give the antibiotic therapy, because whenever you are performing the laparotomy or the open surgery, you're handling the gut microflora, and whenever you are handling the gut microbiota, you have to give the adequate antibiotic therapy, particularly the broad spectrum antibiotics. So for the supportive management, what you have to do, you have made a diagnosis of the intestinal obstruction. You have to NPO the patient till your management, for whenever your management is supportive or your management is surgical. It depends upon you. So you have to NPO the patient till further orders. You have to give a good hydration therapy, at least 3 liters of the fluid. You have to go for the nasogastric decompression, so that any kind of the oral secretions or saliva or gastric or pancreatic secretion which are present, they should be aspirated, and they should relieve the symptoms of the patient. And you have to give the antibiotic therapy prophylactically. But if you're planning a definitive treatment, a surgical option for the patient, you have to put the patient on you must have to put the patient on the antibiotic therapy, because you're handling the bacterial flora of the gut. So you have to give the antibiotic therapy. Plus, in case of the surgical treatment, if you are performing an operative decompression, the first thing you have to perform is operative decompression. You have decided that we are going to perform a surgery or laparotomy. You have to give a midline incision starting from the xiphoid process extending down to the symphysis pubis, or maybe if you are not giving that extensive incision, the incision can be down to the umbilicus, right? Or you have to extend it down from the umbilicus to the symphysis pubis, starting from the xiphoid process to the symphysis pubis, a midline incision in which you also enclose the umbilicus as well, right? So you do the operative decompression. How you do the operative decompression? You open the abdomen through the midline incision. You cut the different layers of the abdomen. You go inside. You open the peritoneum, and then you reach the intestine. And whenever you are whenever you're reaching the intestine, you have to find the proximal or the dilated portion. You have to bring out that dilated portion, and then you have to cover it with the gauze, and or the mesentery, so that the the blood circulation should be, the temperature should be enough, the blood circulation should be restored. So all these things you have to do. And then what you do is you go inside. You can see here, you put a nasogastric or orogastric tube. More specifically, you put the orogastric tube, and then you push the contents from to distal to proximally, so that if there are any contents which are present distally, they should go to the proximal side, and from there they should be aspirated through that orogastric tube which you have placed. So this is called as the operative decompression. So while you're performing surgery, operative decompression is very much important. If you didn't decompress the patient initially, you can decompress the patient intraoperatively. What you have to do is you have to put the orogastric tube. You have to push the contents from distal to proximal, so that back into the stomach, and from the stomach, the all of the contents, they should be aspirated through the tube, right? If we talk about the surgical, specific, definitive surgical treatment, in case of the band adhesion or the band compression. In case of the band adhesion, what you have to do is, actually for the adhesions, you have to give a conservative treatment for the 72 hours, right? Most of the times, the adhesions, they respond to the conservative treatment. Like you put the patient on the fluid therapy, you give a good antibiotic control, you pass the nasogastric tube for the decompression. Plus, you also give a good hydration control, and you also discontinue anything orally. So you NPO the patient for the 72 hours. So most of the time, if you do all these things conservatively, you can manage the patient, the band adhesions particularly conservatively. But if the symptoms are persistent, and if the symptoms are not, they are still persistent, they're not being resolved. So what happens is that you have to go for the surgical options, but you at least you have to give 72 hours to the treatment, the supportive management, because most of the adhesions, they respond to the conservative treatment. But after the 72 hours, if the symptoms persist, you can shift to the surgical treatment. For the surgical treatment, what you have to do is starting from the duodenoduodenal flexure, from where the duodenum and the jejunum are connected. You start from the duodenoduodenal flexure down to the cecum. You examine the whole of the gut. You pull the gut out. You perform the laparotomy. You go through the midline incision. You open the abdomen. You reach the intestine. You identify the duodenoduodenal flexure, and then you take all of the intestine outside. You examine and you find any kind of the adhesions. Most of the time, you break the adhesions, right? Like some of the adhesions which are very juicy or which are very smooth, and you can break those adhesions. You can simply cut those adhesions, or you can at least using your finger, you can break those adhesions. But most of the time, the smaller adhesions, they're not surgically treated. But if you find a single dominant adhesion, you find out that adhesion, you localize that adhesion, and then you remove the adhesion, you cut that adhesion. But those adhesions which are small and they're multiple, they are left like that. You do not intervene. You left them like this. You just remove you just have to remove the dominant adhesion, and then you have to leave the other adhesions in place, and then you have to put the patient on the supportive treatment for the 72 hours, and then most of the time the other adhesions respond. And you can also do the band compression. Like in this picture, you can see here that there was particularly a band, a string which is compressing the extraluminally, it is compressing the gut lobe, and because of that the patient presents to you with the intestinal obstruction. But here what you do is you just identify the band, you remove the band, you go by the scissors, but you don't cut it because you don't have to open the lumen of the intestine. So you have to separate that band from the rest of the bowel. That's how you remove the adhesions and the bands. sometimes you have to keep in mind that most of the time the laparoscopic surgeries are being performed, right? For specifically for the appendicitis or the hernias, but you have to keep in mind that in case of the laparoscopic cholecystectomy, or you have to insert the 3 ports, right? From the 2 ports you enter the gaspers, because you perform most of the time the instruments are being passed through those ports, and from one port most of the time the camera 5 millimeter port is created and the camera or is basically inserted. So you have to keep in mind that the laparoscopic surgeries, in case of the laparoscopic surgeries, adhesions are formed, right? Because most of the time the patient comes to you with the hernias, and plus with the hernias as well, and the adhesions are also formed. So you have to take the laparoscopic history if the patient undergo any kind of the laparoscopic surgery, because after the laparoscopic surgery is inguine, particularly the incisional hernias, plus their incidence is about 2 to 4%, plus the adhesions as well, they can also be formed. So you have to ask the patient about these as well. So sometimes what happens that laparoscopy can be used for example, if you're performing a diagnostic laparoscopy. So what you do is you put the laparoscope inside, you find out the adhesions, you just pull out one portion of the intestine outside, you find out the different kind of the adhesions which are available. But particularly this is the laparoscopic cholecystectomy, in which you can see the gallbladder is being stretched out, and you can see different kinds of the stones, these are being removed. But what happens is, like, sometimes you can also use laparoscopy for the intestinal, just for the diagnostic laparoscopy for any kind of the intestinal obstruction which may be present. So you have to keep all these things in mind. Plus, if we particularly talk about the surgical treatment for the adhesion, and but same, you have to manage the patient conservatively for the 72 hours. You have to give a good intravenous rehydration therapy. You have to put the nasogastric intubation, and ultimately you have to do the laparotomy. And laparotomy, I already told you, you have to build up the patient, you have to resuscitate the patient for the 72 hours. And whenever you have resuscitated the patient, then you have to go for the laparotomy, and you find out the dominant adhesion. You remove the dominant adhesion, one single dominant adhesion is being removed, but rest of the multiple small adhesions, they are left in place, and you give at least 72 hours to heal or resolve spontaneously. There can be some kind of recurrent intestinal obstructions, which are because of the adhesions. So in case of those adhesions which are particularly recurrent, and there is more likelihood of the recurrence for them, you go for the adhesolysis, or you go for the enterolysis. Particularly that segment of the gut is being removed. You can see here, if this is the portion of the this is the portion in which the adhesions are formed again and again, you have to do the adhesolysis, or you have to do the enterolysis, in which that particular segment of the gut is being removed. There are other procedures as well, like the Nobel's lication operation. There can be other. You just have to memorize the names of these procedures because they are very much complicated to understand. But for that, you just have to keep in mind, if a patient is coming to you with intestinal obstruction, and you find out that they are particular adhesions, and then for that you have to give us conservative treatment for 72 hours. Then you have to open the patient if the symptoms are not being resolved, and then you have to remove one dominant adhesion, and you have to leave the rest of the adhesions and give them time to resolve spontaneously. The other procedures for the recurrent intestinal obstruction are adhesolysis, enterolysis, Nobel's lication operation, or Child-Philip transmesenteric lication, or you also perform the intestinal intubation. In case of the intussusception, what particular treatment you are going to do is, again, intussusception is causing the intestinal obstruction. So all the intestinal obstruction are managed in the same way. Like you have to give fluid therapy, intravenous fluid, 3 liters of the fluid per 24 hours, broad spectrum antibiotics, particularly for the 72 hours, and you have to put the patient with a nasogastric tube for the compression as well. See, broad spectrum antibiotics, intravenous fluids, barium enema, and then a nasogastric drainage as well, because all of the fluid is being drained by that. And sometimes the decompression is also performed by the barium enema, and you perform the decompression until there is air or full air passage or full air enema passage. So you perform the barium enema as well. Broad spectrum antibiotics, intravenous fluid, barium enema, and the nasogastric drainage. These are all important treatment modalities for the intussusception. For the surgical treatment of the intussusception, you give a midline incision, you open the abdomen in layers, you go deep inside, you open the peritoneum, and then you reach the intestines, and you have to find out the point of the intussusception. For the intussusception, what you have to do is you have to do a maneuver, and you have to pull the intestine. You have to squeeze it from distal to proximally. This is the proximal segment, this is the distal segment. Most of the time, I told you that most of the time it's the proximal segment which is going into the distal segment of the intestine. So what you do is you squeeze the distal segment, and by squeezing the distal point or the distal segment, actually what you do is you try to push back the proximal segment. This is the contracting entering layer, and particularly you have to squeeze the distal segment. You can see here, this was the distal segment, and this was the proximal segment. And what you do is you find out the intussusception, the point of the intussusception. You squeeze the proximal segment, you squeeze the distal segment, and try to push it proximally, right? But the thing is this, the most important, the last or the terminal part of the intussusception, which involves the cecum and the appendix, this is the most difficult one to push back, right? So you have to be very vigilant. You have to do it with all the expertise, especially the terminal part, which involves the cecum and the appendix. They should be squeezed very carefully. So if we talk about the intestinal obstruction in case of the neonates, let me tell you, there are 2 things which are very much important. One is the intestinal atresia, which can be duodenal atresia, jejunal atresia, or ileal atresia, and the other modality is Meconium Ileus, right? So what happens that in case of the intestinal atresia, which can be which can be duodenal atresia, or which can be jejunal atresia, or which can be ileal atresia, out of all these, duodenal atresia is the most common in the newborns, right, in the neonates. So most of the time, in case of the duodenal atresia, the patient or the baby or the newborn that presents with a bilious vomiting, which is projectile in nature, right? So whenever a newborn is vomiting, especially the bilious vomiting, you have to make a diagnosis of the intestinal atresia. So how you are going to treat that, you can see here that this is the proximal duodenum and this is the distal duodenum, and basically this is the point of the atresia or the stricture. Young children or the newborns, they can have atresia or they can have stricture as well, but most commonly the duodenal atresias are very much common. And you can see here This is for the duodenal atresia. You give the patient a good hydration therapy. You NPA the patient for 24 hours, and then you have to perform the surgery for the duodenal atresia. That particular surgery for the duodenal atresia is called as duodenoduodenostomy. What you do is actually this is the portion of the duodenum which is being the atresia. You resect that portion. This is the proximal, this is the distal duodenum. You bring them closer to one another and you resect that segment, and then you do the end-to-end anastomosis. You can see here this is the end-to-end anastomosis. So that particularly duodenal atresia is being removed. Same here in this picture. Again, the different kind of the step. You can see here in the previous picture, the part was resected. The loops were bring closed down, both the proximal and the distal segment of the duodenum, and then there were end-to-end anastomosis was established, which was seen in this picture, that this is the end-to-end anastomosis, which is called as duodenoduodenostomy. And you have to keep in mind that we perform the surgery for the patients who have the duodenal atresia and the newborns which are coming to you with the projectile bullous vomiting. So projectile bullous vomiting is the cardinal sign for the duodenal atresia. There's another procedure, there's another entity in case of the newborn, which is called as Meconium Ileus. So in case of the Meconium Ileus, actually what happens that there's not so much good activity of the intestine. Particularly, you can say that there's some kind of involvement of the neuropathic pathways, and because of that, the peristaltic activity is not so good, and the stool which is present in the newborn, that is called as a meconium. So that meconium is actually most of the time is not very much fluid, and it is hard, and it is deficient of the water, and because of that it is hard in consistency. And for that also, that hard segment is because of the ileus that cannot be excreted down. So for that, what you do is the procedure you perform for that is ileostomy, and you resect that particular segment. You bring out you bring out the loop of the ileum, terminal ileum specifically, and to the exterior of the abdominal wall, which is called as ileostomy, right? You can see here in the picture, this is the ileostomy. This was the stomach, the duodenum, the first part, the second part, the third part of the duodenum, then jejunum, duodenojejunal fracture you can see here, then down to the ileum. You put the actually what you do is resect the segment, and you bring down that ileus segment as a hernia, and that's called as an ileostomy. So you perform the surgery for the Meconium Ileus, and you can see that this is end-to-end ileostomy site. And now that was about the the basic management, whether for the small bowel obstruction or the large bowel obstruction, and some kind of the obstructions related to the children, particularly to the newborns, like the intestinal atresias, like the duodenal atresias, and then we'll talk about the Meconium Ileus as well. But now we'll be talking about the acute large bowel obstructions, and what kind of the treatment modalities we are going to perform in the acute large bowel obstruction. Let me tell you that in large bowel obstruction, the constipation is more pronounced, and distension is also pronounced as compared to the small bowel obstruction. In small bowel obstruction, vomiting was more pronounced, but in large bowel obstruction, distension and the constipation is more pronounced. It can be like the constipation can be absolute constipation or relative constipation. If the patient is passing the flatters but not passing the stool, this is called as relative constipation. And if the patient is not passing the stool, not passing the flatters, then that is particularly called as absolute constipation. So depending upon the type of the obstruction, whether partial obstruction incomplete or the complete obstruction, the symptoms vary depending upon the relative or the absolute constipation. So in case of the acute large bowel obstruction, the symptoms would be same, but constipation would be more pronounced. But we talk about the small bowel obstruction, like most of the time there was adynamic and the dynamic obstruction. And again, the intraluminal causes, the extramural and the intramural causes. So if we particularly talk about the acute large bowel obstruction, there are same intraluminal causes which can be fecal impaction, foreign material, foreign body, or these can be the causes of the acute large bowel obstruction. And if we talk about the extramural causes, most of the time they are the divertical. Intramural causes include the diverticular causes, right? And in case of the particularly extramural causes, there can be some ovarian cancer, which are compressing and causing the obstruction. There can be endometriosis. So we have divided into three. The causes for the acute large bowel obstruction can be intraluminal, extramural, or intramural. So the intraluminal causes includes the fecal impaction or the foreign body, foreign material. And for the intramural causes particularly, that involves the particularly if we talk about the intramural causes, they can be diverticular diseases or the carcinoma, which is that can be sigmoid adenocarcinoma or the colonic carcinoma. So most of the time these are the intraluminal causes and extraluminal causes, or the ovarian carcinomas or the endometriosis. For that you perform the hemicolectomy, right? It can be a right hemicolectomy or it can be left hemicolectomy. It depends upon the segment of the bowel which is being involved. Like if the segment is starting from the cecum, ascending colon, and then the transverse colon, hepatoduodenal flexure in the transverse colon, or the splenic flexure, sometimes you perform the hemicolectomy, right? But if there's involvement of the cecum, ascending colon, hepatoduodenal flexure, till the transverse colon, you perform the right hemicolectomy. And the segments which involve the splenic flexure down to descending colon, sigmoid colon, or rectum, so that involves the left hemicolectomy. So the treatment or the surgical options, it depends upon the type of the obstruction, which involves the right-sided or left-sided, depending upon the parts of the large intestine which are being involved in that. So this is how you do that. In case of the most of the time involving the right, or it can be left. But in case of the segments which are involving starting from the cecum, ascending colon, hepatoduodenal flexure, transverse colon, and then the splenic flexure, most of the time colostomy is performed. How you perform the colostomy, actually, starting from here, you can see here, this is the part of the cecum, the ascending colon, the transverse colon. This is the hepatoduodenal flexure, and this is the splenic flexure. This is the descending colon, the sigmoid colon, and down it is the rectum, right? So if the obstruction is involving, it's because secondarily to the carcinoma, involving from the cecum, involving this ascending colon, hepatoduodenal flexure, and then here the transverse colon, you perform hemicolectomy, right? But for that, involving the sigmoid colon or sigmoid colon, or this is the rectum basically, or the descending colon, you perform the colostomy. You resect that particular segment from the splenic flexure down to the rectum. The sigmoid, the descending and the sigmoid colon is being resected, and you bring out that resected portion as a colostomy to the exterior of the abdominal wall, and a pouch or colostomy bag is created in which the you actually you actually bring out the colostomy outside, and you keep the colostomy there for months, depending upon for especially. Now let me tell you, for some conditions in which you can perform the primary anastomosis, and some conditions in which you cannot perform the primary anastomosis, right? If there was a perforation, or if there was an element of sepsis, right? You do not do the primary anastomosis. But now the question is, what do you mean by the primary anastomosis? That means that you resect, you find out the part to be resected, you resect the segment, and you do the primary closure or the primary anastomosis. You close the both segment, the resected segments, and you anastomose them. That's it. There's the primary anastomosis. But like if there was no perforation, or if there was no element of the sepsis or bacteremia, you do the primary anastomosis just right after the resection. But in case there was a perforation, or there was particularly an element of the sepsis or the element of the bacteremia, you actually do not do the primary anastomosis. You create the colostomy, or you create the ileostomy, and then what you do is you keep the colostomy for a reasonable time. You examine the gut every day, and then after, when you're satisfied, and the gut mucosa is fine, and the ischemia or gangrene that is not, the gut is viable, and you do the colostomy reversal, and then you do the secondary anastomosis, right? So the conditions, in infective conditions, in case of perforated conditions, in case of sepsis, you do not do the primary anastomosis. Instead, you do the colostomy. But in case of surgeries in which there was no perforation or no element of sepsis, you just do the primary resection, and then you do the primary anastomosis. So that's how you do the colostomy, and then ultimately you do the colostomy reversal, and obviously after the colostomy reversal, secondary anastomosis is established. Same way you perform the ileostomy. You can see here in the picture, this is the loop of the intestine which is being held, and then this is being bring out, and the ileostomy bag is created. There are two procedures. One is the Hartmann procedures, and the other is Pulse-Wickelick's procedure. But first, let's just talk about the Hartmann procedure. What you do in a Hartmann procedure is like, this was the resected portion, right? This is the transverse colon. This is particularly the segment, which is the splenic flexure, and this is the descending colon, right? So you have to resect this portion. Let's suppose that this was the gangrenous portion, or this was the cancerous portion, whatever the etiology is. The proximal portion and the distal portion, they are resected. Actually, what you do is you bring that proximal procedure, the proximal portion, as the colostomy, and you keep the other distal portion inside. This is called as a Hartmann procedure. So what you do in a Hartmann procedure is, actually, you only bring out one colostomy, and the proximal part of the resected segment, or the proximal part of the healthy colon, is bring out as a colostomy, and the distal part is actually that stays there, that is kept in the abdomen, inside the peritoneum, same place. That's called as a Hartmann procedure. You can see here, this was stoma that was bring out, and the distal portion was kept in that place. Bowel segment removed, and the Hartmann pouch non-functional intestine closed and left in abdomen. This is not bring out, this is left in the abdomen, right? The other procedure is the Paul-Meconium procedure. In Paul-Meconium procedure, what you do is you bring both the segments to the exterior through the abdominal wall. Let's suppose this was the resected portion, And this is one colostomy, and this is the other colostomy. In Hartmann procedure, you were bringing only one colostomy, and the other non-functional Hartmann pouch that was kept in place, the distal portion particularly. So that was the Hartmann procedure. But in Paul Michalek's procedure, you resect the segment, the proximal and the distal, both of them are bring out at the two colostomies, and this is the Paul's Michalek procedure. And later on, what you do is you anastomose both of them together when you do the reversal of the colostomy. So there's also for some older person, there's a self-expanding metal stenting. You also, in case of the palliative surgeries in which, or older patients in which you cannot perform the hemicolectomies or colostomies, you do this, which is the self-expanding metal stent. You place that stent, and that relieves the obstruction. In case of the caecal volvulus, again, what kind of the management or the surgical options you have available in case of the caecal volvulus? One is a cecopexy and other is a cecostomy. In case of the cecopexy, what you do is, whenever you at the medial border of the cecum, at the intermesenteric border, we know that we have a blind end of the loop, which is called as appendix. So in case of cecopexy, what you do is that you again, whenever the resected segment is the segment is being resected, you bring out the cecum and appendix back to their normal position in the right iliac fossa. This is called as a cecopexy. And in cecostomy, what you do is again you make the cecostomy bag at the exterior, just like that. So in case of the caecal volvulus, whenever there is a twisting, you remove that twisting, you correct the volvulus. You don't have to resect the segment, but you have to perform cecopexy, or you have to go for the cecostomy. In cecopexy, what you do is you bring out the cecum with appendix at its normal position in the right iliac fossa, and in cecostomy, what you do is you bring out the cecum as to the exterior through the abdominal wall, just like the ileostomy or the colostomy. Okay, in case of the sigmoid volvulus, what you do is sometimes sigmoidoscopy is performed, and you try to, if the obstruction is intraluminal and the cause is the fecal impaction or the foreign material, the cause is not the cancer, in that you perform the sigmoidoscopy. You enter the sigmoidoscope per annum, and from the rectum into the sigmoid. And this is the tube which is being placed into the cecum. You visualize all of the cecum, and then you relieve any kind of the obstruction which is being present. But most of the time, the obstruction is because of the diverticulosis. So for that, you have to do the laparotomy, and you have to identify the different kinds of the diverticulos, and you have to cut, or if there's a multiple diverticular present, you have to resect that segment, and then you either do the primary anastomosis if there's no perforation, or if there's no there's no perforation, you just have to do that you have to do the primary anastomosis. So these are the parts of the sigmoidoscope. You can see here, this is the video camera lens. This is the point through which you give the irrigation. This is the light source, and this is the instrumental channel. The other management strategy for the sigmoid volvulus is again, elective sigmoid colectomy. And the other is endoscopic decompression. In the elective sigmoid colectomy, you have already done the sigmoidoscopy. You have found out the cause for the obstruction, and there is a sigmoid volvulus. So for the treatment of the sigmoid volvulus, you do the sigmoid colectomy. The part of the sigmoid colon that is being removed or resected, this is a sigmoid colectomy, and you do the primary anastomosis of the rest of the bowel left it there. And the other is the endoscopic decompression, just like putting the endoscope, and you perform the decompression. The other management strategies is, again, you can see here, this is the resection, and sometimes there can be gastrostomy as well. The other management, you can see here, this is the big sigmoid volvulus. what you do is you have to resect all this portion, and then the rest of the healthy or the viable tissue is being restored or anastomosed. But the thing is, you should know the viable and the non-viable segment. So how would you differentiate between a viable segment and a non-viable segment? A viable segment is the one in which, obviously, when you relieve the obstruction, the color will change. It will change to lighter from darker, and you can feel the mesenteric pulsations in a viable segment. In a non-viable segment, if you even relieve the obstruction, the color won't change. The color would be same, darker and gangrenous, and there would be no mesenteric pulsations as well. Plus, in case of the viable segment, there would be mesenteric pulsations. In case of non-viable, there would be no mesenteric pulsation. Plus, the most important thing is a peristalsis. In a viable segment, whenever the obstruction is relieved, whenever the obstruction is relieved, there would be peristalsis. But in case of the non-viable, there would be no peristalsis. So you have to keep in mind because you don't resect the viable segment. You just relieve the obstruction and you leave the viable segment as it is, and you give the 4 to 5 days for the gut to return to its normal activity. But in case of the non-viable segment or the gangrenous portion, what you do is you resect the segment, you do the primary anastomosis, and you give at least 4 to 5 days for that anastomosis to be established. And actually 4 to 5 days, minimum 4 to 5 days is needed by the anastomosis to work out. So you have to keep all these things. The viability is very much important, and the viability is important to make the actually decision about the resection, or you're not going to resect the segment. So this was a large sigmoid volvulus, and for that you have to resect, and then you have to do the primary anastomosis. The other you can do either the Paul Meconium procedure or the Hartmann procedure. In which Hartmann procedure, what you do is you just resect the pathological part of the intestine, or gangrenous part, and then you bring the proximal site as the colostomy, and the rest of the non-functional part of the colon is kept inside the abdomen. The other is a Paul Meconium procedure. In the Paul's Meconium procedure, what you do is, this was the sigmoid volvulus, this is the segment resected, and both the proximal and the distal edges, they are bring outside as two independent separate colostomies. This is called as a Paul Meconium procedure. Okay, so this was all about the acute large bowel obstruction. Now we're going to talk about the chronic large bowel obstruction, and let's just talk about the causes for the large bowel obstruction, which are the functional causes, which include pseudo-obstruction. There can be idiopathic megacolon, or there can be Hirschsprung disease. The other organic causes, they include the extrinsic intramural, which are the endometriosis, which are intrinsic intramural strictures, or they can be intraluminal. So these are, again, the chronic large bowel obstruction causes. In case of the acute large bowel obstruction, the causes are same, like the volvulus or the volvulus or the intussusceptions involving any kind of the part. But in case of the chronic large bowel obstruction, there can be functional causes, there can be organic causes. Functional causes, pseudo-obstruction, Hirschsprung disease, or idiopathic megacolon. And inorganic causes include extrinsic intramural, which are basically the ovarian cancers or the endometriosis. Intrinsic intramural involves the strictures, and intraluminal, like the fecal impaction in their particular layer. And intrinsic intramural, there can be carcinomas as well. What would be the symptoms in case of the chronic large bowel obstruction? Constipation, again, extensive distension, and alternating bowel habits, vomiting and dehydration. Although this vomiting and dehydration is not so much pronounced in case of the chronic large bowel obstruction, but in case of the chronic, these chronic large bowel obstructions, Most of the time there is a subacute intestinal obstruction, and sometimes the patient passes the stool, sometimes not, and sometimes the patient is not passing the stool but passing the flatus. So you can say that the chronic large bowel obstruction, the patient have relative constipation and extensive dilatation or distension, but vomiting and dehydration, they're not that much pronounced. They're more common and more pronounced in a small bowel obstructions. So for investigation, again, you will do the barium enema, and obviously you will also perform the CT scan or the X-ray rect abdomen. So this is the X-ray rect abdomen, and you can see the dilated gut loop, or gut, which are indicating about the chronic large bowel obstructions, and you can also see these dilated portions in the CT scan as well. So what are the management treatment options? Again, you do the laparotomy or stenting, you do the surgical management, like the resected portion, and then you do the anastomosis, colonoscopic decompression, or you put the patient on a conservative management. The other adynamic obstructions, this was all about the dynamic obstructions. Now we're going to talk about the adynamic obstructions, in which there is no peristalsis and there is no mechanical obstruction. The first is the paralytic ileus. The paralytic ileus means that the gut is in the paralysis, and there is no peristaltic activity, although there is no mechanical obstruction, right? And you can see here. But most of the time, in case of the paralytic ileus, this is the this is the content with it which is being present in the, but the peristalsis is not being generated. This is how actually the primary and the secondary peristaltic waves, they push the bolus in the intestines. But if the paralysis of the paralytic ileus is there's no peristaltic activity, then what happens is there would be no bowel movement, right? So there are different varieties for the paralytic ileus, and most commonly it's a reflux ileus, or it can be post-operatively, because most of the time post-operatively they can be, gut motility is reduced, and there can be some neuropathy, especially those surgeries, abdominal surgeries, or the laparotomies in which we are dealing with the abdomen. So the post-operative paralytic ileus is very much common, but if it's more than 72 hours, then you have to investigate the case. Metabolic causes, or they can be infective causes for the paralytic ileus, but most common is a post-operative paralytic ileus, or they can be because of infection that lead to the septic ileus. So you have to keep in mind the septic ileus as well. So the clinical features, they include abdominal distension, vomiting, and gas-filled loops of the intestine. So obviously the patient will complain about she didn't pass the stool, she didn't pass the flatus, or they would be complain of constipation, or they would be complain of vomiting or abdominal distension. And whenever you order for the radiographic modality, you see the gas-filled loops of the intestine in the radiograph. For the management of the paralytic ileus, most of the time they can be, it's being managed conservatively. You just put the nasogastric tube and you do the nasogastric suction or the decompression, or you just have to correct the electrolyte imbalance, and you just have to good fluid therapy. You have to discontinue fluids or food, any kind of fluids or food orally. You have to NPO the patient, and you have to do the nasogastric suction, and you have to balance the electrolyte fluid imbalance. And other is elective intra-abdominal surgery if the conservative treatment fails. Okay, so let's talk about the small intestinal pseudo-obstruction. You can see here, sometimes the patient can present to you with kind of a pseudo-obstruction, which is actually there's no mechanical cause. So in that small intestinal pseudo-obstruction, the patient sometimes passes the stool, sometimes he didn't pass the stool or flatus. So for that, you put the patient on a metoclopramide or erythromycin. And there's another category which is called as colonic pseudo-obstruction. And in case of the colonic pseudo-obstruction, there's again, the cause can be neuropathic, or there's no mechanical cause, and there's no peristalsis. The syndrome is particularly causes Ogilvie syndrome, in which there's no mechanical obstruction, but there's no peristalsis. And in case of that, you can see the dilated gut loops. See here in the picture the dilated gut loops. So in case of the colonic pseudo-obstruction, what kind of the treatment modalities we have? You can, because it's a pseudo-obstruction, there's no mechanical obstruction, so you don't have to perform the surgery in most of the cases. You have to put the patient on the conservative management, specifically like the IV neostigmine, or you have to do the colonoscopic decompression. And because sometimes if the patient is not responding with the IV neostigmine, you have to put the patient on atropine, and if the patient is already on the atropine, you have to do the ECG monitoring. Plus, in case of those obstructions, in which all the conservative treatment fails, although the surgical option is not very helpful, but still to rule out any mechanical obstruction, you have to do the surgery. So this was about the colonic pseudo-obstruction, and sometimes in case of surgery, you do the colostomy as well. You can see here in the picture, this is the colostomy side which is being performed. So this was about today's topic, and we have discussed about the different kind of the management strategies, starting from the small bowel obstruction to the large bowel obstruction, and different kind of the conservative management and different kind of the surgical operations we have available for the intestinal obstructions. So thank you for watching sqadia.com, and for other lectures, keep watching sqadia.com.